Greetings, everyone. Steve Cole here with Ada County Paramedics and your Access Training team. And today I want to talk to you about femur fractures and traction splints. So as you may guess, the traction splints and traction splinting and management of femur fractures is another one of the skills we're going to be doing in our July block training. So first I want to talk a little bit about kind of like the causes of femur fractures. And you think, well, duh, they break their femur. Well, let's break it down a little bit more because understanding the causes will help you understand the risk factors and the treatment and stuff like that, things that kill the patients. So when we look at causes, we kind of break down femur fractures into high energy trauma, low energy trauma, and the other weird stuff. Now, when we talk about high energy trauma, it's no surprise that's mainly men who are under 40. Again, no surprise. And alcohol is involved. Duh, right? In other words, men doing stupid stuff while intoxicated. And that includes your motor vehicle accidents, your motorcycle accidents, your auto versus pedestrians, etc., so forth. And most of these high energy trauma tend to be mid-shaft femur fractures. Now, I'm going to qualify this by saying that in another one of the lectures, we're going to talk about all the things that cause pelvic fractures on high energy trauma. And, you know, pelvic fractures and femur fractures often go hand in hand. And when in doubt, worry about the pelvic fracture first before the femur fracture. Then we worry about the low energy mechanisms, which is really men and women equally over 40, especially men and women over 70. And what are they? You guessed it. What do we go on most commonly in this age group? Ground level falls. So ground level falls, these are spiral fractures. These are osteoporotic related, bone density related fractures, etc. And again, these sometimes involve the pelvis, but usually they're what we think of as hip fractures. So they're the proximal third of the femur, And then there's everything else. This includes your gunshot wound victims, which affect all ages. And it's just really, yes, men play with guns and alcohol more often than women, but the recipients can be across the age spectrum. And the early, when we talk about the early treatment of femur fractures, gunshots and violence were really a major cause of those in days gone by. Also industrial accidents, whether it be agricultural industrial accidents or actual industrial accidents. Also athletics, and athletics tend to involve a lot of knee injuries as well. And I don't mean just like patellas, I mean substantial knee injuries. So we need to consider those. And if you're in someplace in a nasty place in the sandbox or elsewhere, IEDs, dismounted IED explosions, in other words, foot soldiers on foot, tend to have a disproportionate amount of femur fractures because these are often, that's an unprotected part of the body. Also with associated injuries. So stuff to keep in mind. Now, why is that important? Because number two, associated injuries are common with high energy injuries. Now, what do I mean by associated injuries? Well, I'm talking about stuff that you also need to be concerned about, and most of these also are a problem with traction splinting. So pelvic injuries, especially. Pelvic injuries, you can't, especially with, we talked about blowout fractures out the back of the acetabulum. Pelvic ring injuries are often mistaken for hip injuries when actually they're pelvic ring injuries. Stuff like that, big problem. Also, head injuries, intra-abdominal and thoracic injuries, especially with the autoped type accidents and the motorcycle accidents. Knee injuries, these are the distal third of the femur injuries that often involve into the epiphyseal plate and or massive vascular injury in the knees. Do not discount these. Knee injuries have a high instance of surgery and sometimes even amputation. Now here's the big thing. 25% of these injuries are undetected in pre-hospital setting. Now, undetected, whether that's because of poor assessment or undetected because they're more subtle, probably split roughly down the middle. But really highlights the need to have a high index of suspicion for these other injuries. Bilateral injuries, bilateral femur fractures usually imply substantial mechanism of injury and are significantly increased in mortality, not just from blood loss, but also from respiratory failure and pulmonary emboli coming from both these fractures. I forget what the exact percentage is, but it was a substantial increase in percentage. Now, just like pelvic injuries, I said there are many types of femur fractures. So there's the oblique femur fractures, mid-shaft, you see right there. There's the comminuted. We see right there, and they're just nasty and broken. You have spiral fractures, which I have actually seen some spiral fractures. We normally think of spiral fractures with abuse in the elderly or in the very young, but I've also seen it just from a larger person turning and twisting on their leg in an inappropriate manner and then pushing off, and just that centrifugal force, just not centrifugal, that but that force with the twisting with additional weight at just the right angle sometimes will do it. And then compound fractures, where it's an exposed or open fracture. Again, knee fractures, fractures to the epiphyseal plate. This is a proximal third. I'm going to get my handy dandy laser pointer. On this one, you can see the proximal third really right at the head or the foot of the femur. No pun intended right there. This could be mistaken for a knee injury. These have a very high complication rate, both in terms of pulmonary emboli and vascular damage, and even amputation, surgical amputation down the stream. The other complication we see is blood loss, and we know that the femoral artery runs beside the femur, but what we don't often appreciate is that there are branches directly off the femoral artery and the vein that go directly into that vascular and go into the bone, and these are also a fracture. You see that there, and the reason is there's a large amount of blood that's produced inside the bone marrow, and it has to get from the marrow space into the vascular space, and that's how it does. Well, unfortunately, that means that when these, especially midshaft femurs, when they break, or proximal third up here, when they break, you can see the vasculature that often gets lacerated or destroyed with that. And you can see right here, when we talk about pelvic fractures, I probably should put this slide in there too. You can see the acetabulum right under there where that femoral artery and femoral vein comes off. You can see why these get damaged and why hemorrhage is such a big issue. Now, when we talk about hemorrhage being a big issue, how much hemorrhage? Now, I'm going to take a moment, and I'm going to just take about 3 seconds for you to pause the video, think in your brain, how much blood loss do we see of femur fractures, and then I want you to see if you came back correct. So take that pause. Okay, now that you're back, ATLS says 1,000 to 2,000 cc's per femur. Now, when I first started, they said it was about 500 to 1,000. This has been upgraded quite a bit. But let's contemplate how much that actually is. Well, that's about 2 liters of Mountain Dew. And I put Mountain Dew up there because we know about young, strong hillbillies doing hillbilly things in the mountains. They all love Mountain Dew. So there you go. About 2 liters of Mountain Dew. And, of course, what would Mountain Dew be without alcohol? And not just alcohol, but good old-fashioned Jim Beam. So that is roughly 2,000 cc's is about 2.5 fifths of Jim Beam. So, which is kind of appropriate. You think, okay, that's a lot. Well, how impactful is that? How much blood loss? That sounds like a lot. How does that affect the patient? Well, we look at the classes of shock. And between 1,000 and 2,000 cc's puts you squarely in class 2 and class 3 shock. So class 1 shock is roughly your compensated shock. You're in the decompensated shock in class 2 and class 3, and you're in irreversible shock in class 4. And you can see, depending on blood loss, you're awful damn close to class 4 if you're up in that 2,000 range with your bilateral femur fractures or whatever the case may be. And then if you had a pelvic fracture on, so on and so forth, bad news. And that's why, I'll take a little sidebar here. I really stress the importance of heart rate in early prediction of shock and trauma. And you can see right here, when you have heart rates above 120 to 140 with altered metastasis or any other symptom, you need to be really concerned. But that's not specifically pelvic or traction splinting. That's just a little sidebar. Tachycardia, do not underestimate its importance. So, point number 5, types of traction splints. Let's talk about all the different types. And what you see there in that ancient image is an example of the Thomas full ring traction splint. And that dates from before World War I. And there's actually Thomas God, what his name is, Dr. Hugh Thomas developed the Thomas traction splint in the early 1880s. That's the full ring traction splint. And in the by World War I, they also had the half ring traction splint to make it a little bit easier to put on because the full ring you had to fit over the leg. And this was a huge innovation. Now, remember, many of the femur fractures that these were used on in World War I were gunshot wounds. So high energy but highly focused trauma that would go through the thigh, shatter the femur, maybe shrapnel, whatever it would be, and then they would pull traction. And mortality from femur fractures from gunshot wounds were about 80% before introduction of the Thomas half ring splint, and dropped to about 20% in 1918. Now, there were a lot of things that played a role in there, including these got over the course of 1914 to 1918, the medical system became better, wound care became a little bit better, surgery became dramatically better, so on and so forth. But this was also partially attributed to that specific thing. Now, the Thomas half ring, believe it or not, I actually trained on this in 1990. It was one of the 2 types of traction splints we had to learn when I went to my first EMT class, both in the military and in Kentucky. Yes, the Thomas half ring. And we had to learn how to tie fancy knots for ankle hitches. Now, that evolved. The other splint I had to learn was called the hair. And you will still see hairs. As a matter of fact, I'm going to back up. You may still see a Thomas half ring out there if you're in some really rural environment. I don't know. But you would almost definitely see hair traction splints sitting on walls in ERs and rural communities, and maybe even on ambulances. And you can see how the hair and with the half ring and the Thomas half ring are pretty much just an evolution. The hair is an evolution of the Thomas half ring. Now, there's another splint out there. You do see it in the military sometimes. It's called the Real Splint. This is the Real Splint. And it's basically a Thomas half ring, but the rings can be reversed. And you can use it to mobilize knees as well because it can be articulated in the middle. This kind of came and went. You do see them, but I want to point out there if you ever see one on in a multi-agency type operation. In the access system, and this is what we're going to focus on, we have 2 traction splint styles. We have the Sager, and I think most of them are going to be the bilateral Sager, and we have the Kendrick traction splints. Currently, Ada County and Meridian carry the Sager. I think Cuno too. I'm not 100% sure. And then Boise and Eagle and Star carry the Kendrick, I believe. Now, and so these are the ones. And incidentally, in block training, we'll have these available, and we'll be playing with these in block training, hands-on. There will also be 2 videos, one on each of these, that you should watch as part of this activity today. Now, the Sager comes in adult, pediatric, and infant sizes. At Ada County, we carry the adult and pediatric. There's 2 big advantages of the Sager over the hair and Thomas style splints. And the big one is it doesn't fulcrum the femur over that half ring, over that ischial bar. It doesn't bend it over. It pushes it directly against the pubis symphysis. So the theory is it's a little bit in line. Here's the problem, is that it puts counter traction against the pubis symphysis, which means if you have a pelvic fracture, it's going to split it wide open. And that's the problem with it. All traction splints have to put counter traction against something, and most of them put it against the pelvis. So you need to be absolutely sure you don't have a pelvic fracture. The other nice thing about the Sager is you pull a specific amount of traction, and we'll talk about how much traction it is, where with the other ones is a best guess. Another advantage of the Sager is you can pull 2 bilateral femur fractures at the same time. So you can pull bilateral, you can use one splint for bilateral femurs. I've only seen one bilateral femur fracture that was splintable in, I don't know how long, in 20 some years. So it's pretty uncommon, but it's a thing. Now, the Kendrick has several advantages over the Sager, and that's very lightweight. These are basically ski poles. And, you have the strap, and you pull, there's not quite a ratchet, but kind of a grabbing buckle you pull to pull traction. It uses a strap up here to pull against the top of the femur and the groin as counter traction. And these are really neat because they are really light, exceedingly lightweight. Boise Fire carries them in their response bags, but they can only splint one leg at a time. But as you see there, and honestly, that's probably not a big deal because I've only seen a couple bilateral femur fractures that were splintable, or one that was splintable. And there you see, it does extend out quite a bit past the leg, though. That's a concern. It does not quantify traction the way the Sager does. It's just your best guess. Which brings me to how much traction. Well, if you know for sure how much weight you're putting on it, it's 10% of body weight per single fracture on a single splint. If you're using the bilateral feature of the Sager, it's 20% for 2 fractures. So 10% of body weight for 1 fracture, 20% for 2. And if you're with the other ones, it's just basically your swag, your scientific wild-ass guess. So you're pulling it until the pain relieves and the extremity straightens out, if it does. Number 7, since we talked about how much to apply traction, how important is it to apply traction? And the answer is maybe not as important as you think. We know that from data from World War I showed a reduction in mortality of open femur fractures, key is open femur fractures, from 80% to 20%. These were mainly gunshot wounds, and surgery was a lot different then, and this was before antibiotics. So the question is, does that still apply today? And most recent studies found no clear difference in mortality of traction splinting versus good regular non-traction splinting. And there's even a statement on this in a bit of research. This is from Mountain Rescue Pre-Hospital Care study, said that traction splints may be no more effective than other methods of splinting. They failed to find anything that shows that absolutely reduces morbidity or mortality. But there's still some advantages. So they still advocate for the use of them, but realize that other splints may also be appropriate. Now, what are the other benefits? Well, the other benefits is it may provide some pain control the way splinting does. If you pull a bone back inside the tissue, the bone survives longer because bone necrosis is a real thing. Bones drying out. If you have neurovascular compromise, reducing that fracture and putting it back in line may restore that, and that may save a foot or a leg. And also remember, traction splinting can also be used as normal splinting just without the traction. So the question is, how important is it? I'm not sure that traction splinting is super important, but definitely splinting is important. Especially when you consider, I want you to take a moment, consider that a lot of femur fractures have associated injuries that prohibit traction splinting, and they are difficult to assess sometimes, especially pelvic fractures and knee injuries that may be just straight splinting. Even if you use a traction splint without the traction feature, is better than traction splinting. That's a personal opinion. But let's talk about when not to use traction splints. So if you have other life-threatening injuries, i.e. massive hemorrhage, you need to get a tourniquet on, as in wound packing, as in chest decompression, as in wrapping that pelvis, as in you name it, those take precedence. Another reason why not to use traction splints, if you suspect a pelvic fracture, don't do it. You can potentially cause severe life-threatening hemorrhage. Cause it by applying a traction splint with traction counter pressure to an unstable pelvis. And if you have a partial or near amputation and you try to pull traction on it and make that near amputation a complete amputation, so keep that in mind. Seriously, though, the bottom line, it's so important to get a good assessment on the pelvis and the knee before you apply traction. Many fractures are associated with pelvic and knee injuries, and they're both contraindications. So bottom line is exceedingly crucial to apply splinting. Absolutely, you have to splint these somehow, but you don't necessarily need to apply traction splints. So you could body splint it. You can to an uninjured extremity. You can use cardboard splints, vacuum splints. You use a traction splint without the traction, you name it. You have to splint it. You just don't necessarily have to use traction. Let's talk about transport decision. And we look at our transport decision, we need to look at trauma triage guidelines and our protocols. So where does femur fractures fall into this? Well, first of all, Ems Discretion, right? If you have a concern for associated injuries, you can absolutely consider upgrading to a trauma priority from that. We look at femur specifically. A single isolated femur fracture without any other injuries is a priority 3. And priority 3s can go anywhere in our system. However, remember that that femur fractures have a high instance of needing surgical capability. So I would probably not take these to a freestanding ER. I would not take these to St. Al's Eagle. Probably not St. Al's Garrity either. I don't know. I don't know if they have inpatient surgical capability there, but just something to keep in mind. Same thing with St. Luke's Nampa. Not so, even though technically they accept priority 3, but we know that these have a high instance of needing surgical repair, very high instance. That you're delaying definitive care in those cases, especially since 25% of the time we may miss an associated injury. Then we look at 2 or more broken extremities, including a femur. So if they have a femur and an arm, or a femur and a lower extremity on the other side, something like that, or an open femur. Well, this makes it priority 2. And where do priority 2 patients go? Priority 2 patients go to St. Al's main campus, and pediatric priority 2 patients can go to St. Al's main campus or St. Luke's Boise, depending on a number of factors. Now, what about bilateral femur fractures? Well, bilateral femur fractures are automatically priority 1, and depending on age, they go to St. Luke's downtown if they're under 14, and they go to St. Al's main campus if they're over 14. And that's pretty much what we do with that. And again, remember, Ems Discretion. I would take I'm going to go back here. And if I have a priority 2, I'm going to really be looking at pelvis, really be looking at all the other factors, and maybe even considering going to priority 1 there, because I'm really suspicious of high energy femur fractures and pelvic injuries. So, is it high energy or low energy? Well, keep in mind that high energy mechanisms of injury should be treated at trauma centers with surgical capability regardless of hemodynamic stability. Because 40% of high energy femur fractures have associated injuries. Half of those we miss. So keep that in mind. And just as I said, many of these patients will require surgery, so choose your destination wisely. And that brings us to an end. And I hope this was informative. Remember, there are going to be some videos on how to apply the Sager and the Kendrick in this activity. Please take time to watch those closely and contact your training officers if there are any questions. Thank you so much.